Good morning, New York State Thoracic Society. My name is Charles Powell. I'm Chief of Pulmonary Critical Care and Sleep Medicine at Mount Sinai, and it's truly an honor and a pleasure to be with you at the assembly this morning. I will be speaking about lung cancer biomarkers for diagnosis and treatment. I have the following disclosures. I will not be speaking about off-label uses of any compounds manufactured by these companies. Lung cancer is the second most common cause of cancer in the world, and it is a leading cause of cancer death in the world and in the United States. In the United States, the number of people who die every year from lung cancer exceeds the sum of those who die from breast, colon, and prostate cancer every year. And so why is that? Two potential reasons are, one, historically, lung cancers have been detected late. Over 50% of lung cancers are typically detected at the metastatic disease stage. Until recently, there was no approved program for screening in lung cancer, in contrast to the long history of screening programs in place for breast, prostate, and colon cancer. But as of 2013, screening for lung cancer with CT scan has been approved, and we would hope and expect that the proportion of lung cancer detected in early stage will increase over time. The second reason is, compared to the unique histology of breast, prostate, and colon cancer, which is adenocarcinoma, the histology for lung cancer is more heterogeneous. In the past, all non-small cell lung cancers that were advanced were treated similarly with combination chemotherapy. But now, with precision medicine approaches in lung cancer, tumors are treated on the basis of histology and molecular characteristics, resulting in a significant improvement in disease response and in survival for lung cancer. But there's still room to do better. There's room to do better in terms of early detection of lung cancer, and there's room to do better in terms of precision approaches for the treatment of early and advanced lung cancer, and therein lies the potential promise for biomarkers. So what is a biomarker? A biomarker is a characteristic that is objectively measured and evaluated as an indicator of a normal biological process, a pathogenic process, or a pharmacological response to a therapeutic intervention. It typically is a biological molecule that can be found in the blood or other body fluids or in tissue. It can signify a normal or abnormal process or a condition or a disease. For us, it's importantly to remember that the promise of molecular biomarkers is that they can provide clinically useful information that can supplement the data that is presently already available when we are making clinical decisions. The clinical utility is key. So let's talk about the potential use case for molecular biomarkers in the setting of lung cancer detection. So we are, as a community, relatively comfortable with identifying demographic characteristics that signify an increased risk for lung cancer, and they are the premise for the eligibility criteria for lung cancer screening right now: age 50, former or current smoker, for example. And we are also becoming more familiar with appreciating that there are radiographic characteristics of pulmonary nodules that signify an increased risk or a lower risk of that particular nodule being a cancer. For example, the lesion on the top left is very round and very smooth, and that has characteristics that have a higher probability of that nodule being benign. In contrast, the nodule on the bottom left is irregular, it's spiculated, it's present in a lung that shows emphysema, so this nodule has a high probability of being malignant. So in the context of screening, we have available to us well-designed, formalized approaches for integrating clinical information and radiological information to assign the probability of nodule findings to being cancerous and to guide management approaches and follow-up to the CT scan that was performed in the context of screening. And this is lung rads right here. So depending upon the size of the nodule, whether the nodule is solid or part solid, then we have a probability of malignancy assigned in the second to last column. And then we have a management approach suggested in the third to last column. We have similar tools available to us to apply in the context of incidental nodules, which of course are more commonly detected than nodules in the process of lung cancer screening. And here's an example of the Fleischner Society criterion published in 2017, which again, separate nodules on the basis of whether they're solid or part solid and on the basis of size, and then provide guidance as to potential follow-up approaches that can range from serial CT scans done in follow-up up to a year out, or consideration of immediate biopsy. So the issue is, can we do better in terms of enhancing clinical outcomes for patients who present with a pulmonary nodule in the context of screening or in the context of the incidentally detected nodule? And again, therein lies the potential promise of molecular biomarkers. To help provide some overview and guidance as to how one can evaluate the potential promise of a biomarker, the American Thoracic Society published this document back in 2017. In this, we outline that there are 4 specific cases for which molecular biomarkers may find clinical utility in the setting of lung cancer. It could be in the setting of risk prediction, cancer detection, diagnosis, or in treatment. The statement also provides an overview on the process for how biomarkers move from discovery to analytical validation of test performance, to clinical validation, and then to clinical utility evaluation. I'll just give a couple of examples here. So in terms of risk prediction, a biomarker then would be expected to assess the probability of cancer developing and being diagnosed over time. A good example of this exists in the sphere of breast cancer, and that example would be the detection of a BRCA2 mutation. For cancer detection, we're talking about a situation in which the cancer is present, but it has not yet been detected. A good example of this in the setting of colon cancer is the Cologuard assay, which evaluates for the presence of colorectal specific mutations present in stool specimens. For a diagnostic biomarker that could be applied to a lung nodule, for example, we're talking about a biomarker that can assess the probability that this finding nodule, in this case, is likely or not likely to be malignant. And I'll give more information about 3 specific examples for biomarkers in this class. And then also we will be talking about biomarkers that are currently in use for treatment, in which we have a situation, the cancer is diagnosed and the biomarker in particular is used to assess the likelihood of response to a particular therapy. And we have many examples of biomarkers that are already FDA approved in clinical use and have demonstrated clinical utility. So the first of 3 lung cancer biomarkers that we'll talk about is the Notify CD2 lung assay, which is comprised of a blood-based assay looking for the presence of cancer-specific antigens. This test has shown performance to have a specificity of 87%. So in essence, this is a rule-in test, meaning if the test is positive, then there's a significantly higher probability that the nodule in the particular patient is malignant. Another example is the Percepta assay. This assay builds upon the concept that in smokers, there is abnormality in the entire lung epithelium. That's field cancerization. And that in the presence of cancer, this cancerization process is even more exaggerated. And these alterations, if detected in the contralateral lung, are associated with a higher risk of that individual having cancer. So this test has been applied to the situation when there is a nodule of indeterminate clinical probability of being malignant. The test has a sensitivity of 97% in that setting. So this is a rule-out test, which means that if the test is negative, then there's a higher likelihood that the nodule is likely to not be malignant, and thus one may have more comfort with a strategy of observation. Another rule-out test is Notify Express Lung 2, which is a test that includes assays in the blood for 2 protein biomarkers in conjunction with 5 clinical characteristics based upon imaging findings and demographic characteristics. This test has a sensitivity also of 97%. Again, it's designed to be considered as a rule-out test. So the analytical performance of these tests is high. However, what we really need to know is whether these tests are clinically useful. And as put forward in the statement, a biomarker test can be considered to be clinically useful if it leads to earlier diagnosis of a malignant nodule without substantially increasing the number of procedures performed for benign disease, or it leads to fewer procedures for benign disease without substantially delaying the diagnosis of malignant nodules. We await robust studies to demonstrate the clinical performance of lung cancer biomarkers in the diagnostic setting. How about in advanced disease? There's a nice paper that was just recently published in the New England Journal that demonstrated that the mortality for lung cancer, adjusted for the decreasing incidence of lung cancer, has declined significantly since 2013 and correlates with the timing of introduction of targeted tyrosine kinase inhibitors against EGFR, the first example of a targeted therapy in advanced lung cancer. This demonstrates the clinical impact of targeted therapy in lung cancer directed by biomarkers of response. The targeted therapy approach leverages the increased understanding about the biology of lung cancer, the appreciation of the importance of the different histological characteristics of advanced lung cancer and early stage lung cancer, and the presence of specific molecular alterations that signify therapeutic opportunities in lung cancer. Over time, since at least 2013, there have been several new drugs identified that target the specific mutations and gene rearrangements shown here on this table and circled in red. Pretty much all of these alterations are detected in adenocarcinoma. So there's a paucity of targeted agents that are specific for molecular alterations that are present in squamous cell and small cell carcinoma at present, but we hope and expect that this will change over time. In lung adenocarcinoma, it continues to change over time. And so the most recent targeted agents to talk about are those that address the very common alteration of KRAS mutations in lung cancer, and we will cover that. But let's start at the beginning so we can understand the principles of the application of molecular biomarkers to direct treatment of advanced lung adenocarcinoma. And so this begins with EGFR, and it was clear that patients who had EGFR mutations, specifically in exon 21 or deletions in exon 19, harbored increased sensitivity in terms of treatment response to tyrosine kinase inhibitors that target EGFR, such that the response rate was approximately 70%, much higher than the response rate to conventional platinum-based doublet chemotherapy that had a response rate of 30%. I think one of the most important clinical trials performed in the setting of targeted therapy for lung cancer was the IPASS trial. This was published in 2009. And in this trial, patients who had demographic characteristics suggestive of having an increased probability of having an EGFR mutation were randomized to receive, for advanced lung adenocarcinoma, either gefitinib, which is a EGFR tyrosine kinase inhibitor, or conventional chemotherapy with carboplatin and paclitaxel. On the top left-hand side, the study demonstrated an overall benefit in terms of progression-free survival in all the patients. However, in a post hoc analysis that was done, it was pre-specified, to identify responses specifically in patients whose tumors had an EGFR mutation present, and in those in patients who had wild type status of EGFR, the data were clear. And it showed that the progression-free survival benefit was present only in the patients whose tumors had an EGFR mutation. And in fact, patients who were treated with gefitinib who had EGFR wild type tumors in the bottom left had a worse progression-free survival. So this really established the precedent and the paradigm that targeted therapies for lung cancer are clinically useful in patients whose tumors harbor the molecular target that is addressed by the therapy. So this is amongst the first, and amongst now the most recent trials is this phase 2 trial to evaluate an inhibitor specific to the G12C mutation in KRAS. So EGFR mutations in the United States have a prevalence of about 5%, whereas KRAS mutations in lung cancers in the United States have a prevalence about 25%, of which 13% of lung adenocarcinomas have a G12C mutation. So this waterfall plot shows that in previously treated patients who now were treated with the KRAS inhibitor, there was a very high probability of response and progression-free survival. This drug is now FDA approved. So there are now many drugs that are available for the treatment of advanced lung cancer. However, there are gaps in our knowledge base and also now in the number of patients who may have access to treatment with these effective drugs. So in a recent study published in Chest, the results of a survey demonstrated that amongst academic practice setting physicians and community practice setting physicians, there are some opportunities for enhanced dissemination of knowledge about the potential drugs that are available for patients whose tumors harbor specific molecular alterations. It's incumbent upon us as pulmonologists, since we typically are in a setting to make the initial diagnosis of lung cancer and to perform procedures to establish a diagnosis, that we ensure that that diagnostic test that is performed includes evaluation for the presence of molecular biomarkers in the setting of advanced cancer. If we don't do the test, then we don't know if the alteration is present. And if we don't know if the alteration is present, then the patient may not have access to drugs that could be very effective for their particular tumor. So here's an up-to-date list of molecular alterations that are present in advanced stage lung cancer for which there are approved therapies. This list comes from NCCN, and it's effective as of January 2022 and is still current even through March. Give you a second to commit this to memory. So for targeted therapy to advanced lung cancer, it's fair to say that since 2013, there's been a significant impact on lung cancer survival that is attributable to the introduction of drugs that are targeted to driver alterations. But there are some challenges with regards to this approach in targeted therapy for advanced lung cancer. One is patients invariably develop acquired resistance to these drugs. And when that happens, there's an opportunity to identify the mechanism of resistance and then use a second or a third line approach, and that has demonstrated efficacy. Secondly, drivers are absent in most lung adenocarcinomas and in a large proportion of non-adenocarcinoma tumors. And third, tumor tissue may not be accessible for the discovery of molecular alterations that would be targetable. So let's take on these last 2 points that I just raised. So for patients who do not have a driver alteration, there is demonstrated efficacy for treatment with immunotherapy. So there's been a recent class of compounds, checkpoint inhibitors, that address and reverse the ability of tumor cells to shut down the immune system's response to the detection and toxicity that the immune system can bring to foreign antigens that are expressed on tumor cells. Tumor cells do this by overexpressing a ligand, PD-L1, that can engage with immune cells that have a receptor PD-1. So drugs have now been developed. These are monoclonal antibodies that effectively block the connection between tumor cells PD-L1 and immune cells PD-1 to then allow the immune system to re-engage and attack tumor cells. This class of compounds have demonstrated efficacy in the second-line setting and most importantly in the first-line setting in this publication in the New England Journal, in which checkpoint inhibitor pembrolizumab was partnered with chemotherapy as a first-line treatment for patients with squamous carcinoma and demonstrated an improvement in overall survival. So checkpoint inhibitors have now been approved and in place for the treatment of advanced stage lung cancer. There are multiple different drugs available to choose from. In part, the selection is based upon the intensity of expression of the PD-L1 ligand in tumors. And here's a table that describes some of the particular options that are available, whether using these drugs singly or in combination. So when we think about selecting patients for targeted therapy with advanced cancer, it's important to ensure that these tumors are evaluated for the intensity of staining for PD-L1, and that is done by immunohistochemistry. And it's imperative that these tumors undergo molecular testing. This is now typically done with next generation sequencing. If that's not available, then an approach using sequential tumor sequencing for specific alterations can be considered as well. A key concept to know is that for patients with targeted alterations, such as EGFR or ALK or BRAF, for example, these patients respond better to specific targeted therapies than they do to immunotherapy. There are some cases in which tumor tissue is just not available or accessible. So in order to identify actionable mutations in the setting of advanced lung cancer, one can leverage the biology of these cancers in which tumor DNA is shed into the blood, and the cell-free DNA with specific tumor mutations can be detected by different blood-based assays. There are now 2 FDA-approved blood-based assays that can be useful in the situation to identify actionable mutations in patients with advanced lung cancer. One is from Garden, the Garden 360 CDX, and the other one is from Foundation Medicine, the Foundation 1 Liquid CDX. Again, these tests have utility, especially in the setting where tumor tissue is insufficient for sampling or inaccessible. It may also be very useful in the setting in which a patient who has been treated with a targeted therapy now demonstrates recurrence of disease in a site that might not be accessible. So in order to identify a mutation that could be treated by a second-line agent, then again, there may be utility to using blood-based assays in that case. These blood-based assays are also referred to as liquid biopsies. So in conclusion, advances in the understanding of lung tumor biology and the tumor microenvironment have led to impactful new treatments that have markedly improved survival for advanced lung cancer patients. Current early lung cancer research focuses on bringing similar progress in terms of adjuvant treatment approaches of resected tumors and of intercepting progression of premalignant and indolent tumors, leveraging advances in the understanding of the biology of these cancers and the experience of treatment in advanced lung cancer. And together, these advances will impact our approaches to lung cancer diagnosis, and we can expect further improvement in terms of response, such that we can expect survival of this disease to continue to increase over time. So I'd like to thank you very much for your attention and look forward to your questions. Thank you very much.